Hello and welcome back to The Deep Dive. We're your shortcut, trying to cut through all that noise and get straight to the heart of complex topics. And if you've ever felt, just overwhelmed by the sheer volume of public health info, especially around something as vital and sometimes really intricate as vaccines, well, you're definitely in the right place today. Our mission is to be your expert guides here, cut through that complexity. We're going to do a deep dive into the fascinating world of vaccines. We'll start by breaking down the fundamental science, the different types, how they work, how they teach your body to fight. Then, and this is key, we'll connect that foundational knowledge directly to a really crucial practical resource, the brand new 2025 U.S. vaccine chart. This one's for ages 0 to 18. We've looked closely at two main sources for you, a detailed medical pearls document. It really breaks down vaccine types and, importantly, contraindications, and, of course, the 2025 vaccine chart PDF itself. So get ready for maybe some surprising facts and definitely some practical takeaways that should really empower your understanding.
That's absolutely right. Think of this as your direct line to getting really well informed without wading through all those dense medical texts yourself. My goal is to help you connect the dots, understand not just what the recommendations are, but why they exist, giving you, hopefully, a really informed perspective on this essential topic.
Okay, let's kick things off. Let's lay down that scientific groundwork first. Before we even glance at the actual schedule, the chart, it's so vital to grasp the basics, the science behind it all. Our Pants Prep Pearl source identifies 5 main categories of vaccines. And what's really incredible, I think, isn't just the number, but the sheer diversity of the approaches. Think about it. Your body can be trained to fight a threat in 5 fundamentally different ways, each one sort of tailored to outsmart a specific germ. It's not just a list. It's a testament to human ingenuity against disease.
It absolutely is. And the core concept, behind all vaccines is actually pretty simple. They train your immune system, they introduce a harmless version or maybe just a piece of a pathogen. This lets your body develop a memory, so it can quickly recognize and fight off the real thing if you're exposed later. What's fascinating, as you said, is how each type achieves this training in a unique way, almost like different martial art styles against different kinds of opponents. Okay, first up we have live attenuated vaccines. So these contain a live but significantly weakened version of the actual organism because it's the closest thing to actually having the infection, but without getting sick, it induces a really strong immune response. That includes both humoral immunity, meaning your body makes antibodies like little guided missiles, and cell-mediated immunity, where special T cells attack infected cells directly. This strong response often means you don't need a booster shot later on.
Ah, okay. So stronger response, maybe fewer shots.
Exactly. But there are downsides. They're less stable, often need refrigeration, and because they are live, even though weakened, there's a tiny theoretical risk they could revert to a more virulent form. So for that reason, they generally aren't given to people with compromised immune systems or during pregnancy.
Right. Makes sense. What are some examples?
Key examples are the MMR vaccine, measles, mumps, rubella, which is actually the only live attenuated vaccine considered safe for HIV patients, provided their immune system is strong enough, specifically a CD4 count over 200. You also see this type for chickenpox, which is varicella zoster and rotavirus.
Got it. Live but weakened.
Correct. Then, moving on from those living vaccines, you have their counterparts, killed or inactivated vaccines. Just like the name says, these contain organisms that have been killed. They're inactive. They tend to stimulate a weaker immune response compared to the live ones, mostly just that humoral or antibody immunity.
So
That often means you'll need booster shots to maintain protection over time. But the big advantage here is safety. They're generally safer for those with compromised immunity because, well, there's no live organism to worry about.
Okay. And examples for these?
Common ones include the influenza shot, the injectable one, rabies, and the polio Salk vaccine. That's the main one used in the U.S. People sometimes remember the K in Salk stands for killed. Also, the hepatitis A vaccine. Then another really fascinating strategy. Subunit conjugate vaccines. These are incredibly clever. Instead of the whole organism, they just present the essential antigens, the parts needed to trigger an immune response. And what's really neat is how they conjugate them. They link these antigens to other things, like toxoids or other antigens, that an immature immune system recognizes more easily. This is often used for bacteria with tough outer coatings, like S. pneumococcal. The infant version is conjugated Haemophilus influenza and Neisseria meningitidis.
That is clever. Linking them to something the body already recognizes. Does that mean these are particularly good for, say, babies whose immune systems are still developing?
Precisely. That's a key strength. They're designed to get a strong response even in an immature immune system. And closely related are subunit recombinant vaccines. This is a specific type of subunit vaccine, but it uses advanced recombinant DNA technology. Essentially, they take the genes that code for important antigens, put them into something safe, often baker's yeast. The yeast then churns out these antigens, which are purified for the vaccine.
Wow. Using yeast as a mini factory.
Exactly. The hepatitis B vaccine, specifically the HBsAg antigen part, is a prime example. And the HPV vaccine, too, which targets those types linked to cancers. And finally, number 5, toxoid vaccines. These are for germs that cause harm mainly through the toxins they produce rather than damaging cells directly. So the vaccine uses chemically modified toxins called toxoids. They're inactivated, harmless. Your body learns to recognize this harmless version, builds immunity. Then, if you encounter the real dangerous toxin later, your immune system is ready to neutralize it.
Ah, so it targets the weapon, not the germ itself.
You could put it that way, yes. The classic examples here are tetanus and diphtheria. They're the T and D in the DTaP and Tdap shots.
I genuinely never realized there were so many distinct ways a vaccine could work. It really reframes how I think about, just getting a shot. So the big takeaway here seems to be that vaccine development isn't just one method. It's highly sophisticated, really specific to the pathogen, and always trying to balance strong immunity with safety.
That connection is absolutely key. Choosing the vaccine type is very deliberate. It's based on how the body best fights that specific germ and the safety needed for different people, which naturally leads us to a really important question. If these types are so unique, are there situations where a vaccine might not be right for someone?
Yes, and that's where it gets really critical, I think. It's not just about what vaccines exist, but also who can safely receive them. Our Pearls document outlines some key contraindications reasons someone shouldn't get a particular vaccine. And this isn't about causing alarm. It's about empowering you with knowledge for safe decisions, for yourself, for your family.
That's a crucial point. Understanding contraindications is fundamentally about patient safety. It's core to any immunization program. Our source clearly lists several specific situations, and it's important to understand the why behind them. For instance, if someone has a known baker's yeast allergy, they should avoid the hepatitis B vaccine.
Ah, like the recombinant one made using yeast.
Exactly. There's even a little mnemonic. B for baker's yeast and hepatitis B, easy to remember.
Okay, that's helpful.
Similarly, a gelatin allergy means you should avoid varicella and some influenza vaccines, as gelatin is used as a stabilizer in those. Then there's thimerosal. It's a preservative, sometimes used in multi-dose vials. If someone's sensitive, they should avoid those specific vaccine formulations. And also neomycin and streptomycin. These are antibiotics used as preservatives in the MMR vaccine and the inactivated polio vaccine. So again, avoid if sensitive to those specific compounds.
Okay, so allergies and preservative sensitivities are definitely things to know about.
Yes. And one of the most critical areas is pregnancy. There's a very important distinction here. Some vaccines are considered safe and are even recommended during pregnancy. Things like diphtheria, tetanus, the inactivated influenza shot, hepatitis B, rabies, meningococcal vaccines. However, and this is crucial, all live vaccines must be avoided during pregnancy.
So that means MMR, varicella.
MMR, varicella, the live polio vaccine, though not the primary one used now, and also the live attenuated intranasal influenza vaccine, the nasal spray version. The reasoning is that while weakened, there's a theoretical risk, however small, that the live virus could pose a risk to the developing fetus. So utmost caution is taken.
A mnemonic for an allergy, that actually makes it sick. It really highlights how vital individual medical history is for vaccination. It's not just a blanket thing. It sounds like bringing your complete medical history to your doctor isn't just, a good idea. It's like bringing the owner's manual to a mechanic, essential for getting the right care.
That's a perfect analogy. And connecting this to the bigger picture, it's really about personalized medicine, ensuring safety above all. It just underscores why open, honest communication with your healthcare provider is absolutely essential for you, the individual, to make sure you get the safest, most appropriate care based on your specific situation. And speaking of those specifics, let's move to where this all comes together practically.
Right. So with that essential understanding of how vaccines work and the safety checks, let's bridge that knowledge now directly to the practical blueprint. The new 2025 vaccine chart for ages 0 through 18 in the United States. This is the document many parents and certainly healthcare providers, will be using. This is where all that background knowledge really pays off.
Indeed. This chart, it's designed as a clear visual guide, and this is really important, these recommendations must always be read with the accompanying notes. You'll see notes written frequently on the chart itself, and those notes contain absolutely vital details, exceptions, specific guidance for certain situations, clarifications.
Okay, so the chart is the map, but the notes are the turn-by-turn directions.
That's a great way to put it. The chart also has these green bars, which show opportunities for catch-up vaccination if someone falls behind or starts late. And for the exact minimum time needed between doses in a catch-up situation, you'd need to consult Table 2, which comes with the full chart documentation. It's a whole system.
Right, so let's dive into some specifics we see on this 2025 chart. What stands out to you as you look at this blueprint for childhood and adolescent shots?
Well, what's immediately noticeable are some of the newer additions, or vaccines getting more prominence. Take respiratory syncytial virus, RSV, that's a big one. The chart now includes RSV-MAB, which is Nirsevimab. It recommends 1 dose for infants aged 8 through 19 months. But again, see the notes, because the guidance depends on whether the mother got an RSV vaccine during pregnancy.
Ah, so it connects maternal vaccination to the infant schedule.
Exactly. And it also lists RSV Abrysvo for seasonal administration during pregnancy, really highlighting that strategy of protecting infants by vaccinating pregnant individuals. Another notable one is dengue, specifically the DEN4CYD vaccine. This is recommended for ages 9-16 years old, but, and this is critical, only for kids who are seropositive, meaning they've already had dengue exposure and have antibodies, and they live in areas where dengue is endemic, constantly present.
Very specific criteria there.
Very specific. And you'll also see Mpox just listed on the chart. Its simple listing implies it's part of the general recommendations now, but you'd absolutely need to go to the notes for the specific scheduling details, as they aren't spelled out on the main chart grid. It shows how coordinated guidance adapts.
It really is fascinating how dynamic it is, constantly integrating new science, new threats like dengue or Mpox. For someone just looking at this chart, maybe a new parent, what do you think is often the most confusing part? Or maybe the biggest misconception?
That's a good question. I think, maybe the sheer density of it can feel overwhelming at first. People might look at all those bars and timings and think it's incredibly rigid, like a set of commands, when in reality that frequency notes instruction is the constant reminder that it's a framework. It needs individual tailoring by a healthcare provider who knows the child's history and the nuances in those notes. It's a guide, not, gospel set in stone.
That's a really important distinction, a guide, not a command.
Right. Now, looking at the common childhood series, the chart lays it out very clearly. Hepatitis B, Hep B, starts right at birth. Usually, it's a 3-dose series. Yeah. Birth, then 1-2 months, then the third dose somewhere between 6 and 18 months. And notice how many series kick off early, often right at 2 months. It really underscores that critical window when infants are most vulnerable. Early protection is paramount.
Like rotavirus.
Yes, rotavirus, RV, starts at 2 months. It can be either the RV1 vaccine, which is a 2-dose series, or the RV5, which is 3 doses. Both start at 2 months. Then you have diphtheria, tetanus, and cellular pertussis, the DTaP shot for kids under 7. That's a 5-dose series.
5 doses, wow.
Yep. Usually at 2, 4, 6 months, then a 4th dose around 15, 18 months, and the final one before school at 4, 6 years. That multi-dose approach is key for building up really robust, lasting immunity. Haemophilus influenza type B, HIB, protecting against a type of meningitis and pneumonia, involves 3 or 4 doses depending on the specific brand used, usually 2, 4, 6 months, then a booster dose at 12, 15 months. The pneumococcal conjugate vaccine, PCV15 or PCV20, also protects against meningitis and pneumonia, different bacteria though. That's a 4-dose series, typically on the same schedule, 2, 4, 6 months, and then 12, 15 months. And inactivated poliovirus, IPV, a 4-dose series as well. 2 months, 4 months, then a dose between 6, 18 months, and the final one at 4, 6 years.
Okay, so those first couple of years are really busy with building that foundational immunity.
Absolutely. Then, as kids get a bit older, the chart continues some series and introduces others. Measles, mumps, rubella, MMR, that's usually a 2-dose series. The first dose at 12, 15 months, and the second dose at 4, 6 years. Varicella, VAR, for chickenpox, follows the same 2-dose schedule, 12, 15 months, and then 4, 6 years. Hepatitis A, HEPA, is also introduced around then, typically a 2-dose series starting at 12 months or older. And influenza, the flu shot. That's recommended annually for everyone 6 months and older. Depending on the child's age and prior vaccination history, they might need 1 or 2 doses the first time they get it. It highlights that ongoing seasonal importance.
That's right, the annual flu shot.
Then moving into the later childhood and adolescent years, you have the tetanus, diphtheria, acellular pertussis, Tdap booster. This is for kids 7 years and older. It's typically given as a single dose around 11, 12 years old. Really important for boosting that pertussis, whooping cough protection, which can wane. The human papillomavirus HPV vaccine also starts around 11, 12 years. This is the one that protects against several types of cancer later in life. For meningococcal disease, there are two main types of vaccines recommended. MenACWY protects against serogroups A, C, W, and Y. That's usually 2 doses, one at 11, 12 years, and a booster dose at 16 years. And then there's meningococcal B, MenB vaccine. That's listed on the chart too, but again, the specific recommendations, who should get it and when, are detailed in those crucial accompanying notes, often discussed around age 16, 18 based on individual risk and shared decision making.
It's really striking how meticulously this chart maps out protection, right from birth through the teenage years. Covering such a huge range of potential health threats, it definitely demonstrates a comprehensive, really forward-thinking approach to protecting young people.
And what's fascinating, coming back to it, is just how often that phrase C notes appears across the entire chart. It really, really underscores that while the chart provides that clear roadmap, those individual nuances, the clinical decision-making based on the detailed notes, they are absolutely paramount. It highlights the dynamic nature of public health guidance and, crucially, the need for a healthcare provider to sit down and tailor these recommendations to each child's unique health story and circumstances.
What a journey that was. We've gone from, the tiny microscopic ways vaccines work, really understanding how they teach the body to fight, all the way to this very tangible, comprehensive 2025 vaccine chart. For me, the real aha moments were about understanding why certain vaccines are given when they are, why some have specific warnings. It just makes the whole thing feel much less like a mystery.
And that's exactly the value we hope you, the listener, take away today. Whether it's for your own health decisions, maybe navigating choices for your family, or honestly, just being a more informed citizen in a world where public health is always being discussed. This knowledge is invaluable. Remember, though, critical thinking is key. Consulting the full resources, especially those detailed notes that come with the chart, and talking openly with your trusted healthcare provider, those are always your best next steps. And maybe a final thought to leave you with. Considering how rapidly science is advancing, we just talked about new vaccines like RSV and dengue being integrated into this 2025 schedule. What new considerations, what challenges or opportunities might arise for vaccine developers and public health officials as they look even further ahead, say towards designing a 2030 or maybe even a 2035 vaccine chart? What might that look like?